Hi, everyone. My name is Lily, and I'm the Billing and Office Manager at Community Health Resource Center. Thank you for joining today's community outreach presentation, I Need a Heart Procedure, Now What?, sponsored by CPMC's Kanbar Cardiac Care Center. Today, we're fortunate to have CPMC's Chief of Cardiothoracic Surgery and Heart Transplant, Dr. Brett Sheridan, here with us to discuss essential steps, options, and considerations for those facing heart surgery from diagnosis to recovery. Before we get started, I'd like to share a few words about the Kanbar Cardiac Care Center. It was originally founded in 2002 at the CPMC Pacific Heights campus and relaunched at the CPMC Van Ness campus in 2022. The center was formed through the generous contributions of the late Maurice Kanbar, who was an inventor, innovator, entrepreneur, but more importantly, a philanthropist. The Kanbar Cardiac Care Center is one of the highest ranking cardiac health facilities in California and offers an array of cardiac services and specialists who use advanced technologies to diagnose and treat patients with heart disease. Its nationally recognized physicians, surgeons, and clinicians are committed to providing excellent, personalized care in a contemporary and welcoming setting. I'd now like to pass it along to Dr. Sheridan to introduce himself and dive into the presentation.
Thank you so much, Lily. It's a treat to be here today. This is a fairly unique audience for me in that I don't often get to interface with the community directly. Most of my talks are to other professionals, whether they be at the society level or at the physician level to referring docs who are my usual customer base. Not many patients self-refer to someone like me who's a specialist. But again, it's a real treat. Cardiovascular disease, which the Kanbar Institute represents, is, as some of you may know, it's the #1 killer of people in the United States on an annual basis, has been for some time. And it wins, unfortunately, by a lot. But with that challenge, it's a huge driver for us to improve, get better, and make a difference in people's lives. A long time ago, when I was in medical school, actually when I was in college in the 80s and then medical school, I thought that cardiovascular disease was the most exciting space in the world. At that time, heart surgery was just starting to hit its stride. And everything that was super impactful went through the path of the heart surgeon, the cardiovascular disease space. Then we got smarter in medicine. There was some technological evolution, specifically coronary stents came into their own in the 90s. And then one of the primary procedures, which I used to do the most of more than anything else, coronary artery bypass grafting, sort of went by the bayside, by the side in the I would say in the 2000s. So that was a huge step up for patients to go from open heart surgery to fix their plugged pipes to essentially go home the next day stent procedure. Now there are limitations to this, but I mean, not having to go to the hospital, not having general anesthesia, not being on the heart-lung machine, not being in the ICU for a day or two, and then not having a 5-day post-operative course in the floor, in the telemetry unit, was just huge, let alone the recovery of going through that physiologic trauma. So, heart surgery is great, but there's actually probably a better way to approach cardiovascular disease. And I say this as a heart surgeon, right? Like I know I make a living in this space, but there are repetitive technology evolutions that have occurred that have made my services less and less needed. Again, thankful for the average person in the community benefits from that, because cardiovascular disease is going to touch everyone. whether it's a family member or yourself, it is so prevalent with the aging process that it's going to touch a lot of people. So having tools, having an understanding of what the offerings are for patients is always critical. So going back to the idea of coronary artery disease and talking about stenting, there were a lot of patients that couldn't have stenting because their coronaries were too calcified. So then they would get referred to people like me for cardiac surgery. Since I would say the last 10 years, there's been remarkable breakthroughs where you can put an ultrasound probe, high frequency ultrasound probe into those coronaries, and you can break up that calcium. So instead of referring the patient to me for surgery, the interventional cardiologist, a different specialist with wires through the groin or the wrist, can go in there and open up that artery with high frequency ultrasound and then put a stent in, something that was unheard of. And that high frequency ultrasound approach is getting enhanced or improved year after year after year. So again, taking away the number of people that actually need open heart surgery. Another huge breakthrough, and this has occurred since 2012 in the cardiovascular disease space, is that the other bit that people wear out is the aortic valve. The aortic valve is the valve that leads from your heart to the main blood vessel to your body. It's called, and it wears out with time, just like your pipes that feed blood to your heart get clogged with calcium. The valve can too. It's called aortic stenosis. That just means tight. It's a fancy word that means tight. And when that valve wears out, it gets super tight, then your heart is working double duty to try to get enough forward flow so you can go for a walk or ride a bike or walk on the beach or hang out with your grandkids. Well, that, again, used to be in the purview of heart surgeons up until 2012, at which point there was a new invention in which the valve could be squished down on a catheter, fed through an artery in the leg, pushed up, pushed into the narrowed valve, and then a balloon blows it up and expands it. So it goes from being 1 centimeter in diameter to being 3 centimeters in diameter and replacing your aortic valve. And you can go home the next day. We call that transaortic valve replacement, transfemoral transaortic valve replacement therapy, or TAVR is what you'll hear. You know, over the last 5 years, the number of aortic valve cases that I do open surgical has probably declined by 50% because of this technology, and rightfully so. It is at equipoise or equal to the 5-year durability of a surgical valve, and probably is approaching 10-year durability of a surgical valve. The reason the 10 year is iffy is because the data just isn't out yet. We just don't know. But every year, those valves are getting slicker and more elegant, easier to apply, and the complication profile is going down. So that's another area where innovation in technology is completely changing how we deliver care in the cardiovascular space. Well, looking ahead, your heart has 4 valves in it. There's the aortic valve, which affects about 1.5% to 2% of the population of it wearing out. There's the mitral valve, which affects probably 4 times more people over the course of their lifetimes of having problems. And the mitral valve sits between the left atrium and the left ventricle, so it's deep inside the heart. Again, historically the purview of cardiac surgery, still the purview of cardiac surgery, but there are no less than 12 new technologies coming down the pike to allow us to repair or replace that valve through a percutaneous approach. So the future looks quite bright for those that need some sort of structural heart fix inside their heart, and they're a candidate for these essentially non-surgical options that allow much less physiologic drama and insult to implant, but also allow I mean, an overnight recovery, to say the least. So you can get back to your life within a week, which is almost unheard of. There's new technology that's approaching the tricuspid valve, which is the first valve in the heart, that also wears out with time, usually secondary to some other problems on the left side of your heart. It's a secondary problem, but those are typically sicker people, and they're complicated and fare less well with surgery. So if we can come to a way of fixing that valve while the patient is, again, less traumatized, they're going to have a better chance of doing well after that intervention than otherwise. Again, it sounds like I'm pitching away from cardiac surgery. I'm not, but cardiac surgery is a big deal. It's resource intensive, both on the provider side, but as well as on the patient side, right? On the back side, it takes a lot of recovery. So I am a huge fan of these new technologies that can provide more elegant solutions going forward. And the future just looks tremendously bright in that space. Now, if you're a patient, let's say you have a cardiovascular disease, you're a senior cardiologist, and you have a problem, and they recommend some testing, invasive testing to see what's going on, or maybe non-invasive testing. I think it's really important, if you're a consumer, you're an average bear, you need to know what's going on out there in the world of medicine. And your first and best resource is always your cardiologist. It's important, though, that your cardiologist can speak to the range of options open to you in some fashion. And if there's any questions or any potential possibilities for an array of approaches, then you ask, say, hey, can you refer me to someone that's a specialist in these lesser invasive things? And oftentimes, a dirty little trick, if you're a patient, is that when we see patients with complicated valve issues, myself and an interventional cardiologist will often see the patient together. So we have a multidisciplinary team approach for the patient. The patient only has to make one visit. They get the informed views of both the surgeon as well as an interventional cardiologist. And so they get the full spectrum of opportunities, as well as the collective wisdom, right? To offer them the best solution for these things. So I think it's always good for patients to reach out and ask for this stuff if they're aware of it. The problem is there's a lot of people out there that really are not aware of what's going on and what's actually possible. That's the first thing. And of course, Dr. Google always opens doors. And that's sort of a mixed blessing. If you're not an expert in the field and you ask a question to Dr. Google, you can go down some rabbit holes on YouTube that can be horrifying. So you have to be a little judicious or cautious. I think another great solution, I think, for patients is talk to their friends to see what kind of encounters they've had, what engagements they've had. You'd be surprised how many people have had procedures and you just weren't aware of. And I think tapping into your social network on these issues can help you develop relationships with different docs you otherwise wouldn't have encountered. That one thing, though, if you get sick and you end up in a hospital bed, you're an inpatient in a hospital, options get narrowed very quickly. And so your ability to navigate that from an elective standpoint, from making choices, gets pretty tight. So even though I'm talking about all this newfangled technology and these super clever ways to fix things, when you're an acute inpatient and you're sick, now that's not the time to you often don't have access to the most clever technology. Not because no one wants to offer it. It's just that usually if you're in the inpatient setting, those options tend to go away, and then you have to be managed more often than not. with an open procedure, our cardiac surgeon. Not always, but again, the options get narrowed pretty quickly. So a lot of this advice about, how to approach procedures that are on the cutting edge or in research trials, those are for people that have been seeing, they have a diagnosis, but they're functioning, they're getting around, and you're just trying to prepare for the future. That's the best way to go forward. There are an array of tests now that patients are tapping into. Either direct consumer is the marketing is direct to consumer, so they're doing it with a fringe doctor referral or with no doctor referral. And one of them is like a CT scan of your heart. You get a calcium score. That has been a validated test, and there's a lot of people in the Bay Area, younger people that otherwise wouldn't get, I would say, a test to look at their heart vessels, or getting that on themselves. It's a safe test, relatively speaking, with low radiation dose, and it's very sensitive. So I have to say, not being a total expert in the diagnostic space on this test and how it applies to 100 different people, I'm in favor of it. When you start getting to invasive tests, then you need a good reason. So if anyone's going to puncture your skin one way or another for some data that they think is important to understand your health and your diagnosis and further treatment, then I think once it becomes an invasive procedure, then you got to have a more disciplined and, I would say, grown-up discussion about risks and benefits. Often, the benefits far outweigh the risks. The risks of these procedures, of what most diagnostic tests, are less than 1%. They're just not zero. And I think everyone needs to be aware of that, whether it's a transesophageal echo to look at your heart after swallowing a probe, or whether it's a coronary angiogram where they poke at an artery with a little catheter and they shoot dye into your coronary to look for blockages, and then they can fix them with the stents like we talked about. But again, it's really important from a patient-centered standpoint to know, is it an invasive test or is it non-invasive? The bar to get a non-invasive test can be much lower than the bar to get an invasive test. And then it's always good to have the discussion with your physician. What's the range of potential outcomes of that test before you get it? So what if the answer is 3? Or what if the response to the test is 2? Or what if the response is 1? Then what treatment plan does that mean? It's always good to have an idea of, the test gives me certain data back. What does that trip as the next step? Sometimes docs will get vague at that point because the range of options are too broad. But again, as a patient, as a customer, as a consumer, I think it's always good to ask the question, and you learn what you can learn. The other, again, from a patient-facing standpoint, it's critical that you have a positive, feel-good relationship with your doc, especially if it's a big-time problem. I think that being comfortable with your physician and you have complex medical decision-making with real-time risks and benefits on the table, I really think it's critical that the patients feel good about it. And if you don't feel good about it, get another doc. No one's feelings are going to get hurt. You as the patient have the control over that. You need to feel like there is a connection and that you can trust that person. And the trust can just be feel good. I mean, you're never going to know. It's hard from a consumer to know the quality of a particular doc. You can go on the internet and you get reviews and all that. But really, I think if you just use the filter of, do I like that person? Do they answer my questions? Do they respect me? Do I feel like they're taking good care of me? I think if you can answer those in the affirmative, then I think you're on your way forward with a longer term relationship, and you can move forward with that person. But if you don't feel right about it, then I would encourage shopping around as much as possible. Now, there are docs that are super specialized and you need what they do no matter what. But that's rare. That's not the majority of cases. So I really encourage people to develop a relationship with their docs and feel good about it and access that as you would any other professional relationship. There's a lot of things I specialize in acute care, super sick people and people with heart failure, people with sudden death, people that need life-saving technology in order to live for another day. I do elective stuff, whether it be bypasses or valves or aortic work, but I would say that's about half my practice. And then the other half of my practice are these super sick people that have no choice in their care. They fell into a hospital that has a relationship with our hospital, and they end up talking to me or whatever, and then I take care of that patient. And at that point, you really are captive to the system that you're in. You can break the orbit in the acute care in that system once you're in that orbit, but it's hard and sometimes it's dangerous. So you got to be very careful about in the acute care setting, especially with high severity of illness events, changing your care midstream, so to speak. I wouldn't advise it unless there's a huge red flag that is causing a lot of uneasiness. Oftentimes, some of the things that I get asked about as a interventionalist or as a surgeon in the after the procedures are done, can I drive? Driving after procedures has, I think, always been, I would say, delayed as much as possible. But given the current technology of cars, you've got power steering now, you have power brakes, you don't have a lot of stress, you have airbags. The conditions on driving have evolved. So don't be freaked out that you're not going to be able to drive after a procedure. There are particular unique events where you can't drive if you have a certain diagnosis or a certain rhythm problem. But again, those are rare. And a good rule of thumb is, if you come into a procedure and have something done, you walk in on your own, you should walk out on your own, right? You walk in, you walk out. So walkie-talkie, so to speak. And that should be the expectations of you or your family member or loved one that is undergoing procedures. If you're supposed to go home the same day and you get admitted, there's a variety of reasons for that. It doesn't mean you need to panic, but it means it's safer to be in the hospital than at home. So something isn't perfect. And we as physicians like things to be as safe as possible before you go home. So that would be a reason why you would get admitted unexpectedly to the hospital. But it doesn't mean that the sky is falling. So I would take that away. I've covered a lot of ground with what I just spoke. And so what I would encourage you all to do is to type in a question. I think that's how we're doing it, or are we allowing people to talk, Lily?
Yeah, so both.
I would like to open the floor. Yeah.
Yeah. Thank you, Dr. Sheridan. That was a lot of really great information. I'm excited to see what everyone wants to hear more about. So please feel free to enter questions in the chat box or Q&A, or you can raise your hand, request to unmute to ask questions verbally. We do have a couple here that were submitted in the registration.
The chat box looks kind of empty, folks. Come on, someone's got to chat in there. So what are some questions that have been?
Yeah, so first question, we have a question about mRNA vaccines causing heart inflammation. And, it sounds like they want to know if the risk outweighs the benefit. if you would recommend that.
That's a great question. I can tell you what the official CDC tagline is, which is the benefits of the mRNA COVID vaccine exceeds the risk of heart inflammation after administration. Now, do I know the primary source of that data? No. Am I an infectious disease expert? No. I do think that COVID itself has opened the door to some inflammatory conditions and some hyperclotting conditions that have led to cardiovascular events. I don't think necessarily it's the COVID vaccine, but they're both are at play. COVID is a bad actor in a unique group of people. It's small in number but real, and mRNA is a bad actor in a really small group of people. But I would never dissuade my own family from having an mRNA COVID vaccine at this juncture based on the data that I currently know.
Great. Thank you, Dr. Sheridan. Next question is also COVID related, and this might be a little bit out of the scope of this presentation, but I'll go ahead and ask it. They'd like to know about the best medications for COVID-affected heart damage besides possible transplant.
Oh boy. So the most of the documented COVID issues with the heart have gone away with time. Do I know what the medical treatments are the best to optimize that recovery after a COVID cardiac mediated inflammatory response? I do not know. I would suspect, I'll guess, that it's the usual regimen of, we have a regimen of about 4 medications we put people on with a weak heart. I suspect we would stack those. But again, we're out of my league on the medical side on this. I am an operator and an interventionalist, so I do things. You're tapping to the sort of the limit of my knowledge with that question, so I apologize.
No worries. Thanks for answering it to your best ability. We have another question here. How can you monitor your heart to identify the possible need for a procedure?
Well, so, the Apple Watch has a lot of fancy things, and it's getting a lot of press right now. You can monitor your heart rate. And to be honest, your heart rate and the rhythm of the heart rate, with that regularity of it, is often a canary in the coal mine for heart badness, so to speak. There's 100 things that can go wrong with your heart, which there are easily. They can all manifest in rhythm and rate issues. So if you have a lot of abnormal findings that are truly abnormal on like a cardio, what do you call it? The cardio device, which you can put your 2 thumbs on and get an EKG, or you're having irregular heart rate issues at a degree that you can't function normally, then that's a sign that you need to go see a doc. And you need to see your primary care provider, let them know, and they'll probably refer you to a cardiologist or a specialist in the space. That's the easiest way. The other thing that I always ask patients when I'm evaluating them is, what's your functional capacity? How much are you doing every day? Are you doing the same amount, or are you sort of reining it in, doing less and less and less? And the best person to ask that, to understand that, is the person's significant other, because they know if they're walking because they're going to the grocery store or they're walking down the street to get the mail, they know if they're losing steam, not able to keep up. So I often am very inquisitive of patients' significant other or whoever's living with them as a secondary source of information, because people tend to minimize, especially men. We're denial people. We deny. Women are a little more in tune and open-minded about their health. But those are gross generalizations, but nevertheless true.
Great, that's awesome. Curious what your thoughts are about like continual monitoring devices, like maybe a Zio patch. Is that something that can help catch the need for potential procedures?
So the Zio patch is very effective, but we use it specifically at-risk patients. So it's a certain subtype of patient that has a certain amount of risk to having a rhythm. So it can either be loss of rhythm, so loss of conduction, or atrial fibrillation or atrial flutter, so super fast heart rates. And I don't know if you can actually get those outside of the doctor's oversight. I wouldn't recommend it unless you just need help interpreting that data. And so I think I would establish a physician relationship before I would do this IO patch, personally.
Right, right. That makes sense. Thank you. Next question. Do you often recommend valve surgery for younger patients versus an interventional approach? If so, why?
Yeah. This is a dynamic, it's a great question and it's on point, but the answer to it is changes almost every year. It also changes based on the context of the patient. So there's this idea that patients have a certain chronologic age. So let's say someone's 50 years old, their chronologic age is 50 years old. But there's also a concept of physiologic age. So even though you've only been alive 50 years, your body's actually aging like a 60-year-old or a 65-year-old, or you can go the other way. Your body's aging like a 40 or 45-year-old. So understanding chronologic age and physiologic age is important not only for healthcare providers, but it's important for the patient to understand. Do they look the same as people in their same age group? And are they keeping up the same? Because that weighs in on the healthcare choices you make for durability. In the valve space in particular, the answers differ if it's the aortic valve and if it's the mitral valve. It differs if you're a man or a woman of childbearing age. So I can't answer that unless I break down each one by those different matrices, which I'm happy to do. But if you want to narrow that question, I'll try to address it with more depth. But right now, we've put the percutaneous valves in young people, knowing that will fail and they will need another procedure in the future, but they can get the next procedure percutaneously. So you're buying time, so to speak. There are other people that they don't have a percutaneous solution, so they have to have surgery, or the percutaneous options just aren't proven enough for someone that's too young, right? The younger you are, the higher the bar is for the reliability of that device. So you don't want to so let's say we have a new technology at CPMC and we're in study and we're enrolling people and they get randomized to different technologies. We're not going to put somebody that doesn't have other health issues into an unproven, untested valve. It just doesn't make sense. So that's what I can do with that question.
Great, thank you. Next question, and a chest CT scan for a lung issue included a comment by the radiologist that I have severe coronary artery calcification. Should I get an appointment with a cardiologist to monitor this?
So it's tricky. I can't offer medical advice on a Zoom meeting, as you might appreciate. But a normal CT scan of the coronaries is a 0 calcium score. And clearly you do not have a 0 calcium score. So I would say a follow-up appointment with a physician familiar with calcium scores and CT scans, of course, is appropriate. You don't have to panic. There's lots of people with positive scans that don't have issues, but you need to follow up on it. Now that you have the data, you're stuck with the outcome and you need to close the loop.
Great, thank you. Next question, let's see. Wondering about the difference between a so-called heart failure event, such as a mitral valve replacement and heart disease. If you had a mitral valve, If you had a mitral or other valve replacement, do you still have heart disease?
If you had, um, so if you have a structural heart problem, it gets addressed and it's corrected, at least for the moment. Heart disease is a big term, and I would say that I use it willy-nilly, or I would say in an unrestricted fashion. Um, Once you carry a diagnosis and you've had an intervention, you are different. Your heart is different, and your risk profile for other things is forever different. So from that point forward, you got to have a certain amount, you have to have a cadence of follow-up with a heart specialist. You don't necessarily have heart disease, but you do need a heart specialist in your life.
Great, that makes sense. Thank you. What are the investigative procedures and treatment criteria options for tricuspid regurgitation?
So tricuspid regurgitation, first and foremost, is usually a secondary event. It means if you have a leaky tricuspid, but not always, but the majority of the time, the cause for a leaky tricuspid valve is that there's a problem upstream, or the left side of the heart, where the mitral valve lives, where the aortic valve lives, uh, where you could have high left-sided pressures because the heart is stiff, or you could have pulmonary hypertension or high blood pressure in your lungs that backs things up. So meaning that the tricuspid valve is leaking for secondary reasons. If it's leaking for secondary reasons, it's really important that you address the primary problem first before you lean into a procedure on the tricuspid valve. So now tricuspid valves can have problems in of themselves. We call that primary tricuspid valve issues, primary tricuspid valve disease. And there are solutions. There's two solutions, one that are percutaneous. One is a clip, which I'm less of a fan of. And then there's actually a percutaneous valve replacement option for the tricuspid side, which I am a huge fan of. That just came on market, FDA approved this year in 2024. And it sure beats cardiac surgery for that problem, if in fact you do need an intervention. But again, most of the time it's medical management first, it's correcting the primary problem, then you address the secondary problem. And if you're talking about tricuspid valve stuff, I would encourage you to see a specialist in the heart space that has dealt with tricuspid valve stuff. So I would put on your research hat in your local environment and try to find out who's treating tricuspid valve disease interventionally, not because you need an interventional procedure, but they're the ones that are sort of the best screeners and can help guide what's next for you therapeutically.
Great, thank you. And we have one addendum to that question.
Sure.
Do these guidelines apply for congenital tricuspid valve regurgitation?
So congenital is a wholly different animal. If you have congenital heart disease, you've probably had procedures before, if not many. And that is a whole different arena. It's its own sort. Adult congenital heart disease is its own specialty bucket with its own set of providers. And yes, I can weigh in on adults with congenital heart disease post-intervention, but it's not my usual practice. And there are cardiologists, so people that don't do procedures, that specialize in adults with congenital heart disease, and I would encourage you to discuss those options with them.
Awesome. Thanks, Dr. Sheridan. When and why would someone need a heart transplant? What are the options?
Yeah, heart transplant. When you need a heart transplant, you're sort of at the end of the road. That means you've had either an acute event or you've had a chronic problem with your heart, and then finally your heart just tipped over and it's failed. And there's no specific one target intervention that we can do, like coronary bypass grafting or stenting. There's no valve replacement, either open or closed, percutaneous. and it means the heart's just not strong enough. And there are two options for patients with that problem. One is to do a machine, we call a left ventricular assist device, or the other is a heart transplant. Both those are big deal procedures, and it doesn't sneak up on you. Like when you're down that path, you've been going down that path for a while. And so you're deeply involved with healthcare more often than not. Now, there are certain people in their 30s to 50s that just out of the blue have an event and they have a heart attack that's so big that their heart can't come back. An example of that recently that was in the news was the CEO of United, Munoz. He was in Chicago. He had a huge heart attack. He got treated, but he actually presented too late. And so he needed a heart transplant. He got that expeditiously. So that does happen.
Got it. Thank you. Would you recommend a heart procedure when there is a risk only or when symptoms develop? Would you please give an example of a situation like that?
Well, if your quality of life is encumbered and your functional capacity is getting limited, then you need to consider at least what the options are. You got to start building a risk benefit profile for yourself through data that you obtain with your physician partner, right? That is in that space. And then there's always a tipping point where the risk gets low enough and the benefits are high enough that you decide to have that procedure. And it's different for different people at different stages of disease at different ages. So I can't give you a flat out response, but the way you think about it is risk benefit, and is my quality of life deteriorating, and I feel it and I know it, that I'm willing to incur some risk to improve it or at least to stabilize it. And that's how I frame it to my patients in clinic. Oftentimes, nobody signs up for cardiac surgery unless they feel like they're under tremendous limitations. So I'm a little lucky that way because you just don't walk in to see a cardiac surgeon unless you go, man, I don't feel it. But for the more nuanced stuff and for the percutaneous stuff, the accessibility is a lot easier. The bar is lower. But again, you do things when you know that you need them, not before.
Great. And I was also curious, I know you mentioned a little bit earlier about elective heart procedures.
Yeah.
Could you share some examples of elective heart procedures?
Yeah, well, I realized just talking, the word elective doesn't mean the same to me as it does to the average patient, the average consumer out there in healthcare. Elective means you're not dying. That's what elective means. It doesn't mean that things are great and I'm just doing this because I want a facelift or I want a blepharoplasty. But the elective means that you're just not real sick and we can schedule it in the future when it's convenient for you and your family member. But I would say that just because it's elective and the risks are lower doesn't mean that you should get a procedure for preventative reasons. I'm not a big fan of procedures for prevention. You don't want to get an invasive, especially invasive cardiac procedure, unless you know there's a real problem that has a certain amount of maybe low probability, but great life risk. So you got to think about things in that context when you decide to pursue a procedure, an invasive procedure. I hope that answers your question.
Yeah, totally. Thank you for clarifying. I heard about a 16-year-old boy who had a virus which caused his heart to fail and he needed a heart transplant. What are your thoughts on this?
It happens more than we like to see. So there's this group of diseases called non-ischemic cardiomyopathies, which is basically a wastebasket. when people have a failed heart and we don't know why, we throw out that nomenclature, NICM or non-ischemic cardiomyopathy. And one of the biggest drivers of that is it can be a teenager or it can be someone midlife or late life. They had a cold, they didn't feel well, they got over that cold, and then at some point, their own body's immune system turned on their heart and attacked their heart and caused it to fail. And we don't know why that happens. There's certain viruses that are associated with that, but it's probably a unique interaction between the viral illness and that person's particular immune system. It's rare, but it does happen. And there's no way to prevent it or know if you're at risk that we know of at this current time.
Got it. Thank you. Another question I have, I've heard, varying things about how long organ transplants last. Curious about the general timeline for a heart transplant. Is it something that you can just get one transplant and it lasts you forever, or do people typically need multiple transplants throughout their life?
A great question. A heart transplant is a miracle that we can do it all. And you can take a heart from someone else and give it to someone else, and it's accepted, is amazing. It's a super complicated process of matching heart to patient from an immunologic standpoint. But there's a lot of things that drive someone's acceptance of that heart, their body allowing that heart to exist in their body, in their immune system, that we don't understand. So basically, we just bombard that patient's immune system, the recipient's immune system, with these drugs that quench the immune system, that dull it, right? So we make it less sharp. So it doesn't attack that new heart and see it as an enemy. Everybody's immune system is a little different. And because of that, the predicting how long a heart will last when we transplant it has been impossible. There are some people that completely immunologically integrate that foreign organ into their immune system and they see it as self, and that heart goes on forever, more than 20 years. And if you biopsy that heart, that biopsy of that heart, that DNA is a hybrid of the DNA of the donor and a hybrid of the DNA of the recipient. So that's a chameleon. It happens. But again, we can't predict it. But that's what drives how long it lasts. Now, can we retransplant people? Yes, and we do. So if the heart wears out, it wears out. And we try to retransplant those folks. The average length of a heart in the United States is about 13 years. That's the median survival with that graft, not of the patient, but of that graft is 13 years. But there's huge variance. And so you got people more than 20 years out with one heart, and you got people, sometimes it doesn't last 5 years. So there's a huge amount of variability there.
Got it. And curious about those, are they like immunosuppressant drugs?
Yes.
Is that exactly something that a heart transplant recipient would need to take continuously after the transplant?
Multiple times a day for the rest of their life.
Wow. Okay.
That's the Achilles heel transplant. You have to take all those pills. And sometimes it can be up to 20, 40 pills a day. It's a lot.
Yeah, that's a lot. We have another question here in the Q&A. Are there any new medications or practices to reduce the blockage of arteries?
We're getting increasingly sophisticated about statins and who benefits with particular statins, high dose statins, low dose statins. And there's this genotyping that's going on in that world based on your particular genotype and family history. So I think the precision around how to dose the statins and when to add more than one statin or certain in particular ones has really moved along. And there are people that specialize in just that. And I would encourage you, if you're in that world, you're at risk for coronary disease, or you're already on a statin and you're wondering if you're having issues, I would follow up on that because there is more precision there. And of course, Silicon Valley, biotech, biopharma center of the world, there are people there that can help you out.
Great, thank you. Okay, that's the end of all of the submitted questions, unless anybody else has anything they want to put in the chat for the last few minutes we have here.
Thank you everyone for your time. I hope this was helpful. It's fun. It's fun answering the questions.
Yeah, it's great. You've shared a lot of really awesome information here. Oh, we do have another question here. Are you aware of any non-invasive ways to repair a mitral valve?
There are no non-invasive ways to repair a mitral valve, but there are ways to do it through a small puncture in the vein in your leg. So it's minimally invasive, or it's percutaneous. You get your valve clipped and you can go home the next day. There's now in study, which we offer, there's a percutaneous valve where we can drop a valve in and repair that, or replace that mitral valve that's leaking, and you go home the next day. But it's not, none of those options are non-invasive. They're just a lot less invasive than surgery.
Got it. Awesome. Thank you. Yeah, thank you for having such an engaging discussion with us. This is a new sort of setup we've done for these presentations, and I think it's really engaging. I think we have one last question.
All right.
What should a patient do with a high calcium serum score? What would be the next step?
Not a serum, high calcium score from a CT scan. I don't know of a calcium serum score.
Okay, maybe this
Can you clarify?
Clarify. Yes, from a CT.
So you just need to follow up with your primary care provider, and then they'll talk to you about it, and or they will refer you to a specialist depending on how that test reads and what your family history is, what your age is, your other medical conditions. But it does need to be followed up through a healthcare provider. Not emergently, but you need to close the loop.
Great. Thanks for reiterating that. I think that was kind of related to one we talked about earlier. Once again, I'd just like to thank everyone for joining the Kanbar Cardiac Care Center for this presentation. Thank you to Dr. Sheridan for taking the time out of your very busy schedule to present and discuss with us about various different heart procedures and answer our questions. The Kanbar Cardiac Care Center will continue to host these presentations on a bi-monthly basis, so everyone can keep an eye out for emails with invitations for future events. Thank you again, everyone. I hope everyone has a great evening.
Great job, Lily. Thank you for having me.
Thank you, Dr. Sheridan. That was great.